So good afternoon, everyone. First of all, I would like to thank JB sir for giving me this opportunity. My topic is anterior uveitis, and I'll be highlighting that anterior uveitis is not so simple. So before beginning, this is a slide for the audience. If you have any question and it remains unanswered, or you are watching this recording in YouTube or some other social media, you can mail your query to drparthapratim@gmail.com. I'll be happy to answer your query. This is a case of 21-year-old immunocompetent girl presented with anterior uveitis, and you can see there were small to medium-sized KPs, and she had raised IOP, and there were some vitreous cells. So when we dilated and examined her, this was the case. So it was a case of acute retinal necrosis, as you can make out from the confluent patches of retinitis 360-degree. So it's very important to dilate each eye and examine the periphery carefully, even in you are dealing with a case of anterior uveitis. Until and unless you examine the periphery, you can't make out that you are dealing with such a dreaded disease. So in anterior uveitis, make sure that the predominant site of the inflammation is anterior chamber. There can be some spillover inflammation in the anterior vitreous, but make sure that there is no inflammation in any other part of eye, namely vitreous or in choroid or retina. So for that, you need to perform a very meticulous dilated fundus examination. Also, you have to remember to take the history of trivial trauma. Sometimes even the fingernail injury can cause some kind of pigment release or mild to moderate anterior uveitis. So it's very essential to differentiate between the cells and pigments in slit lamp. So also you have to remember that the topical phenylephrine, which we often use with our mydriatic drops, can cause pigment release, especially in elderly individual. There may be a lot of pigments when you dilate them after a long time. So you have to differentiate between the cells and pigments before you call it a case of anterior uveitis. This is my case number 2 and 3 together I want to present. The first one is 40-year-old male and the second was 28-year female. The first patient, there was no complaint of redness and ocular pain. There was minimal blurring of vision for 3 to 4 months in left eye. The young lady complained of severe pain, severe redness in left eye, and also intolerance to bright light. When I checked the other eye also had inflammation in the 40-year-old male, and in female, the other eye was white. So it was a unilateral case. So now let's go into this case. The first case, from the history, you can make out it has a chronic course and the insidious onset. That means the patient is not aware how the disease has started. The second case, it has an acute course and it has a sudden onset. And when you further examine, you can see the iris nodule in the first case, absence of congestion, and there are a lot of mutton fat KPs in this first one. Whereas the second case, there are marked congestion of the eye, very few fine KPs, no iris nodule. So you can easily make out that it's a case of granulomatous and the lady is having a non-granulomatous uveitis. So based on that, now we know there are certain phenotypes or certain disease which can present with granulomatous uveitis and certain disease which can have a picture like non-granulomatous uveitis. The same thing I applied and investigated the patient, and the first patient was diagnosed as a sarcoidosis, and the second patient we found the HLA-B27 positive. So Wood's classification or clinico-pathological classification may be an ideal way to evaluate a patient with uveitis in your clinic. So it can give you a very important findings to start examining, lead to that clinical signs and investigate your laboratory test. On the pros of the test, this classification is very easy to apply in your day-to-day practice. The downside of this classification is not definitive. There are often overlapping and pattern changes. For example, the first case I showed, the sarcoid uveitis, the sarcoid sometimes can present as non-granulomatous uveitis also. So you have to keep that in mind when you are dealing with Wood's classification. The case 4, the patient with severe complaint, diminution of vision, referred to Uvea clinic. The patient was detected, the entire finding was detected incidentally when patient came for a routine workup, denied any history of redness, ocular pain in the past, and the ultrasound showed an old retinal detachment. So old rhegmatogenous retinal detachment can have actually anterior uveitis like picture, and you no need to investigate such patients if they are giving history, relevant history. So this is case 5 and 6. This is from JV sir's archive. Perhaps it's so old that I may not have joined ophthalmology when sir managed these cases. So the first one is the 32-year-old man with hypopia and uveitis, and the second one was 8-year-old girl with persistent hypopia and uveitis. And both the cases were not responding to the topical steroid and cycloplegic he was prescribing. So at that time, this is, I think you have seen this slide many a times, what is your diagnosis? So the diagnosis is, sir performed AC tap, and if the first case, he found the filaria, microfilaria, and the second case, there was basophilic cohesive tumor cells, which were suggestive of retinoblastoma. So it's very important that if any anterior uveitis is not responding to conventional therapy, always rule out muscularate syndrome. Next important point I want to highlight, always pay attention to the iris. This tissue can give you a lot of information. For example, in first right-hand side, you can see this pattern can lead you to the diagnosis of Fuchs uveitis. The second one, that's iris nodule, can give you the clue that it's a granulomatous uveitis. The third one, that atrophy of the iris, can give you a clue that you are dealing with maybe you are dealing with a viral uveitis. So just coming to my last entity, the treat anterior uveitis in children very carefully. Always remember the signs I termed as ABC. Asymptomatic children, bilateral, band keratopathy with white eye, that means there is no congestion, and chronic codes, beware of these symptoms, these signs, beware of these signs, because this can be the presenting symptoms of signs of juvenile idiopathic arthritis. So referral to a rheumatologist is must. You have to use topical steroid very judiciously, and the most important is you have to follow these patients very closely. I will just conclude with the slides with the mnemonic anterior. Always remember, anterior chamber is involved predominantly in anterior uveitis. No other parts of the eye has significant inflammation in anterior uveitis. Traumatic uveitis should be kept in mind when you are dealing with anterior uveitis. Examination of the posterior segment, especially the periphery, the careful examination of the retinal periphery is must in all cases of anterior uveitis. Rule out muscularate syndrome, especially in the extreme of the ages. If you are examining a children or an old patient, try to rule out the muscularate syndrome in them. Iris details can give you a lot of information to decode the cause of uveitis. Pay attention to each finding and always examine the patient before dilatation. And old rhegmatogenous retinal detachment can sometimes present with uveitis like picture. Beware, don't unnecessarily investigate the patients. Try to take a meticulous history, do a B scan, and then come to the diagnosis. Last but not the least, many of the cases you need to send this patient to rheumatologist, be it a case of HLV27 or, as I mentioned, in JIA associated uveitis. Unnecessarily, you should not treat these patients with topical steroid and oral steroid, because these are recurrent conditions and often require long-term therapy with systemic or topical steroid, which may lead to the development of cataract or glaucoma. So referral to a rheumatologist or starting early immunosuppressive can actually help us to prevent this kind of complication in these patients with anterior uveitis. Thank you.